Acum, mâine? A,
Vai ter um pico, vai ser aqui.
Dacă vreți să mai ziceți câteva cuvinte că o să fiți în live feed, adică pentru ziua 2, și după care trecem la filmul care să meargă pentru audiență, că nu l-au văzut ieri cu MF-ul, și după care trecem la cazul și la operație. Totul durează 10 minute. Ok. Good morning. Thank you for attending East Perspective and Endourology Day 2. We'll be starting our live surgery sessions at 8:45. But for now, a short presentation of the University of Medicine and Pharmacy in Bucharest, Carol Davila, and then we'll switch live to live surgery faculty with 2 cases. You will see the cases before, performed by Dr. Salaheddin Yusuf, a PCNL, and Dr. Rashku, a flexible uteroscopy. Thank you again for attending East-West Perspective in Endourology.
Bucharest, Romania's vibrant capital, blends rich history with modern energy. Known for its lively cultural scene and warm hospitality, the city is a dynamic hub of education, innovation and healthcare. Its renowned medical university attracts international students, offering cutting-edge research and world-class training. Carol Davila University of Medicine and Pharmacy gets its name from the French doctor of Italian origin, Carol Davila, who along with Nicolae Crețulescu founded the National School of Medicine and Pharmacy in Romania in 1857, the first of its kind. In 1875, the Students' Association was created, the Medical Students' Society of Bucharest, which exists to this day. Throughout the years, UMFCD has kept providing the highest quality of medical education, creating fulfilling careers, and being the first home of important personalities such as Nobel Prize laureate George Emil Palade and other prominent names in medicine such as Anna Aslan, Nicolae Paulescu, Victor Barbesh, and many more. Today, UMFCD is an international educational and research hub where students from all regions of the world join together in our international student modules. The high-quality education is reflected by the university's rankings. The Faculty of Medicine enables students to earn the Doctor of Medicine, MD degree, also recognised internationally, as well as the possibility to enter postgraduate studies. In the 37 university teaching hospitals in Bucharest, postgraduate studies can be continued through residency programs in 58 different specialties, as well as master's and PhD programs. The diploma is recognised across Europe and other countries like the USA through IAAR accreditation, and the graduates have the opportunity to stay in Romania for residency programs. The Faculty of Dentistry enables students to earn the Doctor of Dental Medicine, DMD degree, also recognised internationally, as well as the right for free practice immediately after graduation. Postgraduate studies can be continued through residency programs in 7 different specialties or PhD programs. The Faculty of Pharmacy enables students to earn the pharmacist degree, also recognised internationally, as well as the possibility to enter postgraduate studies. Postgraduate studies can be continued through residency programs in different specialties, as well as master's and PhD programs. Our newest Faculty of Nursing and Midwifery will soon be available in English for international students. There are over 4,100 members of teaching and administrative staff members supporting this numerous educational capacity. Students have very active organisations, such as the Society of Medical Students from Bucharest, the Bucharest League of Dental Medicine Students, the Society of Pharmacy Students, the Romanian Student Society of Surgery, the Scientific Organisation of Medical Students, or the Walter E. Dandy Neurosurgical Club. Through these organisations, students organise activities such as blood donations, mock entry exams, international congresses, surgical hands-on workshops, medical mobile units for rural areas. Student Entrepreneurial Society of UMFCD aims through its actions to encourage entrepreneurial activities of students and graduates through an active relationship with the business environment, thus developing entrepreneurial culture and the opportunities it offers in the realisation of business plans and professional visions. It achieves so by organising multiple workshops and events, such as the week-long Student Entrepreneur course. The university offers a complex sports centre that allows for the practice of various sports such as aerobics, table tennis, fitness, basketball, swimming, etc., as well as an outdoor sport complex which comprises 6 clay tennis courts and a mini football court with synthetic grass. Apart from that, our active global alumni community is frequently involved in the development of our students and future colleagues. Psychological counselling in specialised university studies provides personalised support for students, helping them to overcome various situations that may impact their experience. This support includes assistance with self-awareness, stress management, and managing emotional difficulties. The university provides students and staff with a large collection of free printed and digital educational resources, ranging from historical books to the latest peer-reviewed published scientific works. Students are able to spend their learning hours in the university library, which is also home to the historical Nicolae Paulescu Museum. The university has been carrying out medical simulation activities since 2020. The Medical Simulation Centre is structured on 6 levels with an area of 2,000 square metres, includes 17 theory and practice, and is equipped with over 35 advanced high-fidelity simulators, along with many other basic simulators, equipment and medical furniture. The Centre for Innovation and e-Health aims to develop students and teachers' skills and competencies in digital innovation and health activities in order to increase competitiveness and adapt to the digitisation of education and health systems. Some of the opportunities for students include conferences, hands-on workshops, simulation training and digital learning resources. The Innovation and e-Health Centre involves students in 4 main directions: big data analysis, creative activities, digital solutions and innovative technologies. The students and teachers of the Faculty of Dentistry will be able to benefit from the many educational advantages of the new haptic technology, the first system of its kind brought to Romania, which will be used at the Laboratory of Digital Techniques in Dentistry of the Interdisciplinary Centre for Research and Development in Dentistry. Carol de Vila University is vitally engaged in research projects both nationally and internationally, with 18 research centres and 37 university teaching hospitals. The university is home to several cutting-edge research centres dedicated to advancing biomedical science and healthcare innovation. These facilities foster interdisciplinary collaboration and groundbreaking research, enhancing both education and medical practice. The Centre for Research and Development of Innovative Therapeutic Structures, INOTER, is carrying out programs and projects focused on basic, applied, development and innovation research in the biomedical field, with an emphasis on the development of novel, personalised therapeutic systems. With an impressive material base, the Centre for Interdisciplinary Research and Development in Dentistry has opened at the University of Medicine and Pharmacy Carol de Vila in Bucharest. Housed within the discipline of Organisation, Professional Legislation and Dental Practice Management, the Digital Dentistry Techniques Laboratory introduces innovative elements, including cutting-edge simulators. The lab integrates advanced technology for a complete digital workflow, enhancing training for students and resident doctors at the university. The Institute of Research and Development in Genomics of UMFCD will be a cutting-edge research facility dedicated to advancing genomic science. It will focus on innovative genomic research, integrating advanced technologies in gene sequencing and analysis. The Institute will aim to contribute significantly to medical and biological sciences, particularly in understanding genetic factors in diseases and developing personalised medicine approaches. The aim of the CareVask project is to develop a multidisciplinary research centre in the field of health with a focus on cardio-cerebrovascular diseases, which represent the main cause of morbidity and mortality in Romania. The centre will provide the material basis for achieving excellence in teaching and research and developing partnerships between UMFCD and other universities and research entities in the field of education, research and innovation. Our university holds many international partnerships, providing students with numerous opportunities for mobilities and studying abroad. This is possible for medicine, dentistry and pharmacy. The Erasmus traineeship consists of a 60-day long traineeship in any European country. Erasmus short term consists in week-long training in multiple countries with specific themes such as health and well-being or green universities. There are other numerous bilateral exchange programs managed by student organizations in all faculties, where students benefit from these exchanges to explore new healthcare systems in a different cultural and social setting. This is possible thanks to the formation of a student network, both local and international.
All of this and more can be found at the University of Medicine and Pharmacy Carol de Vila, where tradition meets innovation, and every student becomes part of a legacy that shapes the future of healthcare. Here, we don't just teach science, we inspire purpose. Join us and become the difference the world needs.
Pornit. Bună dimineața, eu sunt Ionuț Nedelcu. Astăzi o să vă prezint primul caz de NLP pe care o să-l facă domnul doctor Vasile. Este vorba despre o pacientă în vârstă de 68 de ani, fără antecedente personale patologice urologice. S-a prezentat la noi prima dată pentru niște infecții urinare recidivate. În momentul de față, doamna prezintă o infecție urinară cu un E. coli, cu un SBL, multiplu tratată în antecedente. La noi a fost complet evaluată. La ecografie s-a decelat un calcul colariform bilateral, calcul colariform pe partea dreaptă. A fost investigată suplimentară, efectuat un CT. Aici avem reconstrucția calculului. Este un calcul coriform clasic pentru domnul dr. Vasile, complet, ce ocupă complet sistemul pielocalicial. A efectuat ulterior și o scintigrafie renală, ce a decelat o funcție de 25,55%. Doamna are dureri colicative intermitente pe partea dreaptă de aproximativ un an, a înțeles riscurile operației și beneficiile și astăzi e propusă pentru NLP pe partea dreaptă.
Vă spun și eu bună dimineața. O să trecem rapid în revistă și cazul de ureteroscopie flexibilă de astăzi. Încă nu ai pus noi cazul acesta. Primul caz de la doctorul Rașcu, vă rog frumos. Este vorba despre un pacient în vârstă de 25 de ani. Pacientul este cunoscut cu istoric de litiază. La vârsta de 10 ani a fost operat de pielolitotomie dreaptă. La noi s-a prezentat în urmă cu aproximativ o lună de zile pentru un episod de colică renală dreaptă. La momentul respectiv s-a practicat ureteroscopie, s-a fragmentat calculul, extras fragmentele și s-a lăsat cu o sondă WJ pe loc. Actual pacientul are multipli calculi la nivel renal. O să vedem și imaginile. Sunt calculi destul de mici, cu un diametru de la 3 până la 6 mm. Densitățile undeva la 830 de unități Hounsfield. Mulțumesc frumos!
And now we're going to switch to life faculty surgery, starting with Dr. Rașcu with the flexible ureteroscopy. Do you hear me, Dr. Rașcu?
Perfectly. Thank you. Good morning, you all. So we're going to start our case for today. And I'm going to be using, of course, my semi-rigid scope and single-use flexible scope 7.5 Charrier from Endourology, and that combined with the automated pressure system from Igaume, the Theodor. Today, most probably we're going to use a 10-12 French ureteral access sheet. Right now we're going to extract the JG stent. You see it already has some incrustation, calcification on it. We're going to smoothly extract it and then go back in onto the ureter and perform something that I do in every of my cases in daily practice, and that's the semi-rigid ureteroscopy. That's quite important in this case because, as you've probably heard before, it's a patient that had a surgery for a ureteral stone that was blocking the ureter, 15 millimeter stone, about a month ago. And I also want to check the ureter. It was a stone that was, that was staying there for about a month before the surgery. So I might have a risk of having developed a stricture on the ureter. It looks quite good so far, the right ureter. So everything is fine, except the edema. I have a good caliber of the ureter, and I'm going to continue until I reach the kidney. I'm expecting it not to be an easy case because the patient had an open surgery for renal stone in childhood, and any open surgery, any open surgery onto a kidney, well, actually modifies the position of the kidney and its orientation, and it might not be easy to reach to easily reach all the calyces, but we will see what will happen. So I'm now putting the guide wire because I don't want to force the ureter too much. Okay. Good caliber. Now the patient has sterile urine culture, of course, but you see I have a bit of turbid environment. Nothing to be scared of, but still just to be cautious, I'm going to harvest some culture, some bacterial culture from the urine, from the kidney. Cultură. Hai să luăm o cultură cu ghid pe loc. And now we're going to do that. Which sheets do you have prepared?
That was the question in the room. What kind of diameter for your
No,
sheet?
I can't hear you any longer.
Do you hear me now?
Yeah, it's not as loud as before, but still, please.
Upon your assessment of the ureter, what is the preferred dimension for the sheet you're going to use?
Well, according to the caliber I've seen, I can easily use 12, 14 or 11, 13 or 10, 12, anything. In this case, we have available which sizes? The 10, 12. Okay, the 10 one. How long is it? 40. Don't you have anything longer than that?
We have 11 French with 50. We have 11 French with 50.
That's perfect. 11, 13 with 50 centimeters. Okay? That's what we're going to use. So I'm going to use 11, 13 French with 50 centimeters. Mirela, hai să lăsăm ghidul pe loc. Ok, ghidul la mine. And now we're going to calibrate the system, the automated pressure system. It's good that you do that before the surgery when the sheet is outside the patient. Just to avoid any troubleshooting during the surgery. And while the instruments are being prepared, if the case goes well, most probably at the end of the surgery, I'm also going to be placing a magnetic stent, especially in this young patient, that I would like to easily extract in an office setting afterwards. But we'll see at the end of the surgery. So always lubricate the access sheet, and now we should calibrate it, right?
Yeah.
Nu-l băgăm, îl calibrăm. Okay, so I'm taking cap out.
Okay.
Please start calibration. Yeah. I have the guide wire in place. Is that okay? Perfect.
It's finished. Okay.
It's finished. I should put the cap on, back on right now. Okay. And insert the sheet. So it goes in smoothly. And do you see my x-ray right now?
Not right now, but
Could you please close the machine? Okay. Schimbăm pe siarm, vă rog. Tehnicul schimbăm pe siarm.
now we can see it. Thank you.
It wasn't connected before. Okay? Nu contează. So I didn't connect this before. Is it okay? Okay. So do you see my C-arm now? Not yet.
Yes, we can see it.
Okay, perfect. So I've placed the sheet, and now I'm going to retract my inner part of my inner element of the sheet together with the guide wire. And you see the sheet in place now on the C-arm too, right?
Of course, we see it clearly.
Perfect. Okay. And now we're going to introduce the scope onto the sheet and see what we have inside. Again, checking the equipment. It's working fine. Okay. Ajută-mă un pic cu cablul ăsta, te rog, uite așa. Așa. Perfect. Și aici trebuie să cuplăm sistemul automat. Ce? Unde vrei tu? Unde vrei tu? Îl cuplezi. Ok. Da, nicio problemă. Nicio problemă, sigur. Ok. Now, do you see the image from my scope?
Yes, we can see it.
Okay, so we're going inside a kidney right now and see what's happening inside. So always start with the pilocalyceal system mapping, check all the calyces. I'm expecting to find in here something that's maybe not easy to access. As a calyx, let's start the system, please. So put it in auto and on 30 millimeters IRP, okay? So intrarenal pressure of 30. I'm going to wait to get to that level. Not the alert, but the target one, okay? Okay.
So the Theodor
Otherwise,
system,
I'm going to have negative pressure and I won't see anything. And I need to have clear vision. See lots of edema around in here. Still, I'm not able to see anything, but now it's a bit more clear. Okay, so far so good. So you see calcifications onto the renal papilla in here. These are the inferior calyces. In here, we have a septum, nothing special. Inside, even more inferior callus. And here we have a stone. You see the stone, right?
we see
But
it,
we're
yes.
going to leave it there and check for the rest of the calluses. And we're going to move smoothly because you might get some bleeding if you move very rapidly here and scratch the mucosa.
Dr. Rashku will be back to you when you start the literacy process. But now we're going to Dr. Salaheddin for the punction time
Okay.
of the kidney.
Okay.
Thank you.
See you soon. Bye.
Bye.
Da.
Domnul doctor Vasile, vă vedeți foarte frumos cu întreaga echipă. Așteptăm să ne spuneți câteva cuvinte.
Încep? Bună dimineața și bine ați venit la Spitalul TH Burghele. Înainte să încep, vreau să prezint câteva cuvinte despre echipa de această intervenție. Nefrorectomie percutană în supine position, noi facem și în prone position și de menționat că toți colegii din Spitalul TH Burghele, urologi, practică cu succes această intervenție. Față de alte echipe de chirurgie urologică sau alte chirurgii, această echipă e puțin mai pretențioasă, puțin mai complexă. Cum vedeți, toți sunt îmbrăcați în halate de plumb care sunt greoaie și deci e o echipă formată din echipa de anestezie, doamna doctor anestezist cu asistentă principală, două infirmiere și, cum vedeți, sunt multe aparate. Aparatul de C-arm, masa care de câte ori trebuie ridicată sau mișcată dreaptă-stângă. Avem acest aparat șoc puls care borcanul se umple și trebuie schimbat, filtrul trebuie schimbat, lucru care îl cunosc foarte bine fiecare, doamnele infirmiere, cunosc foarte bine ce au de făcut. Mai avem, câteodată o să vă arătăm și astăzi, niște calcul mai dur, unde nu se poate fragmenta cum trebuie cu shock puls și vom folosi acest aparat, litoclast. Deci vă prezint echipa mea, doamna Adriana, doamna Mariana, fermiera Alina, infirmiera Gina și cu ocazia asta, cu echipa mea minunată, vreau să mulțumesc conducerea Spitalului TH Burghele pentru această organizare, domnului profesor Jenga pentru eforturile făcute și echipa organizatorie care a făcut eforturi foarte puternice și mai ales tuturor sponsorilor. Avem de față un caz, deci e o pacientă, acum a prezentat-o colegul, calcul coraliform e mai complex. Este un calcul coraliform tip A. Cum vedeți, piesă bazetală, calicială superioară, primară, secundară, calicele mijlociu și inferior. Cum se știe, uitați, am făcut desenul respectiv, marginea creasta iliacii, coasta a 12 care este foarte scurtă, deci este un spațiu foarte îngust, cum vedeți. Așa, introducem substanța de contrast, masa puțin mai sus, tremuri. Așa. Deci, cum vedeți aici, nu avem mari șanse să facem stone free într-o singură ședință, pentru că nici nu ne mai permite timpul să facem cum am făcut ieri, cheers. Deci, avem două variante. Ori atacăm acest calice superior secundar și mergem mai departe spre bazenet și calicele inferior, sau avantajul această poziție supine position ne permite să ajungem chiar la acest nivel, din calicele inferior până la calicele superior. Pentru că față de prone position, creasta iliacă ne permite să ne sprijinim cu utaca nefroscopului la maxim. Deci, încerc să funcționez calicele inferior secundar, adică acest calice. Pentru că, intrând în acest calice, pot să iau și piesă calicială inferioară, apoi bazenitală și cât pot din piesă spre calicelui superior. Aici, dacă observați, calicele inferior este paralel cu ureterul și să nu forțăm nefroscopul, că nefroscoapele care le folosim sunt mini-perc ștorți, L, și sunt super față de alte nefroscoape acum 20 de ani, sunt foarte sensibile. Începem procedura. Deci, cum am spus și ieri, direcția puncției este la 110 grade cu suprafața pielii. Cum observați, deci eu acum se mișcă, mă apropie de calcul, sunt în direcție bună, nu există mare spațiu între papilă și calcul, simt calcul, l-am simțit. Masa puțin mai sus, vă rog frumos. Nu vine substanța, nu pot să încep procedura dacă nu-ți vine un pic de substanță. Reluăm puncție, ne întoarcem de unde am pornit. Eu acum simt calculul, trebuie să-l depășesc. Asta e problema la calculul coraliform. Masa mai sus, vă rog frumos. Încă un pic masa mai sus. Eu nu folosesc ecograful pentru că m-am obișnuit de 30 de ani fluoroscopic. Când e nevoie, solicit pe colegul meu, doctor Radavoi, dar nu este cazul. Eu simt calculul și încerc să introduc substanța. Nu, bagăm dama asta din nou. E funcție mai dificilă, nu trebuie să ne temem. Aștept, mai băgat substanța. Deci eu simt calculul și n-am spațiu. Așa că s-ar putea să fiu obligat să îl depășesc cu forța și acum introducem ghidul, care nu înseamnă dacă am puncționat, înseamnă că o să ne se ducă și ghidul. Lumina, nu văd pe ecran. Așa, uite, fă să-l văd așa, că nu mă dau seama ce s-a întâmplat cu... L-am înduit? Așa. Acum facem incizie pentru... Ia, așa. O să-mi trebuiască să mi aducă așa. O să fie o dilatație mai grea, pentru că calculul este foarte dur și trebuie să trec celălalt. Pe lângă, să avansez cel puțin 5 mm ca să trec cu teacă. Folosesc fascialul, primul fascial de cât e 14 sau... Aici mare atenție, foarte mare atenție trebuie, pentru că sunt cu ghidul partea moale la limite. Ai răbdare, Adișor? Stai, merge? Ha? Da, trebuie să mă retrag. Dați din cauza spațiului, cum sunt ghidul s-a îndoit și trebuie să le schimbăm și repuncționez. Ia. Da, nu știam ce aveai în... Pe aceeași incizie lumbară, ia, dă-ne așa. Uitați, ne arată exact unde s-a înduit ghidul. Ușor, ușor, că îmi vine multe substanțe. bagă-mi. Eu simt calculul. E problema cu ghidul. S-ar putea să, dacă nu și nu, o să tai vârful ghidului și să fac direct dilatație până la nivelul calculului și atât. Acum s-a dus mai bine, un pic mai ușor. Asta așa, lasă-mă așa, gata. Introducem facialul de 14. Nu mișca ghidul până ajung, așa. Nu ne supăra foarte tare prezența substanței în spațiul retroperitoneal. Merge mai greu. Mă apropii de papilă. Simt calculul. Mai avansez un pic. Ajunge. Dăm și mie. Deci o să folosesc până apropierea renicului de acest obturator, care este de 18 șarie. Ca v-am spus și ieri, avem 2 teci și 2 obturatoare diferite, 16 și 18. Introducem obturatorul mai subțire, de 16. Încet cu substanța. Să ne sprijinim pe zona asta mobilă. Introducem teacă. Avansăm prin rotire. M-am apropiat. Nu. Stai, ai răbdare, adișor. Ia, ghidul cum e. Un pic mai așa. Vedeți, ieri v-am spus că de obicei nu păstrez ghidul, dar acum suntem obligați că vârful calculului ne-a împins un pic. Țin. Ne ajută, cine ne ajută pentru cu apă, să vedem exact endoscopic unde suntem. Suntem aproape de intrare, care nu am perforat complet. Mai verificăm fluoroscopic. Mișcăm ghidul puțin. Se vede cavitatea. Este ok. Băgați un pic de substanță. Ia. Mai avem puțin până la... Ia. Ghidul s-a înduit aici. Ne retragem în ghidul. Vezi aici s-a înduit ghidul. Încerc să bag porțiunea asta, uite așa. Ia. Așa. Ține tacă. Dăm obturatorul. Exact suntem la marginea paranchimului, unde nu ne lasă calculul să trecem. Acum am avansat un pic, adică se vede de aici, uitați. Nu, să nu tragi. Știu. Ține puțin așa. Nu am ce să fac de așa. Ia, ieșim. Bagă substanța acolo. Tot pe ghid intrăm, că suntem la marginea. Trebuie băieții să vină să mă împingă pacientul ăla, că sunt exact. Ia. Da. Deci am forțat, calculul este foarte dur, am colusat, nu e nicio problemă că marginea, avem până avansam un pic, să comprimăm marginea paranchimului urinal cu tacă nefroscopului. Ne dați, da, se notrot bine să Deci trebuie să facem loc să... Uitați, deci sunt aici, uitați, e marginea paranchimului renal. Se vede, aici se vede ușor mucoasă și trebuie să... Este o fază foarte, foarte importantă, că nu trebuie să te miști. Nu e bine. Nu e așa, da, uite. Așa cum v-am spus și ieri, nu am reglat aspirație. Uitați, aspira foarte mult și nu mai ai... Da, e bine, hai. Să-mi pregătiți și litoclastul, da?
Domnul doctor Vasile, într-adevăr, un caz extrem de dificil.
Acum, când ne îndreptăm spre zenet, putem avansa cu teaca. Uiteți marginea tecii aici. Acum o vedem, deci trebuie să mă duc, avansez până să văd marginea tecii. Încă mai am. Se avansează foarte greu. Așa. Acum uitați, se vede marginea tecii. Asta care o vedeți lucioasă este marginea tecii. Așa, eu acum vreau să folosesc litoclas ca să...
Domnul doctor, ne auziți?
Da.
Un caz într-adevăr foarte dificil și vă felicit pentru puncție. Vreau să zic câteva cuvinte. Dorim să vă adresăm întreaga noastră apreciere și recunoștință pentru contribuția remarcabilă pe care ați avut-o la dezvoltarea chirurgiei endourologice în țărișoara noastră, mai ales în Spitalul Burghele. De fapt, domnul doctor, pentru mulți dintre noi, dumneavoastră ați fost medicul care ne-a introdus în această tehnică destul de grea.
Unul dintre.
Vă mulțumesc mult pentru tot ce ați oferit comunității și oferiți comunității noastre medicale. O să vă lăsăm puțin acum ca să mergem la doctorul Rașcu, care deja cred că a terminat intervenția. So,
Da.
going to Dr. Rașcu now.
Okay. Stai un pic.
Do you hear us, Dr. Rașcu?
I do hear you. Just a bit of a tense moment because, well, I've kind of finished the surgery. I mean, performed some laser lithotripsy, extracted some fragments. Unfortunately, in a previously operated kidney, especially in an open fashion, you might get some orientation problems and some problems related to the alteration of the normal position of the kidney. Increase the pressure a bit. It's negative. I don't want it to be negative. Just. Oh. Okay. Then stop the machine. Pune spălarea la loc. Oh. So it's on.
So
increase. Just a second. Just you know, fine tuning for the machines. My IRP is negative. I want it up. It's -14. I want it up.
Dr. Rașcu, we'll be back to you because Dr. Salaheddin has an important step
connected.
now. We're switching next to Dr. Salaheddin.
Oh, okay. Now it should be working, okay?
Ia să vedem puțin radiologic cum suntem. E bine. Hai.
Vă vedem, domnul doctor?
Da.
Și vă și auzim.
Am o rugăminte să treci ghidul pe sonda, să vedem că sonda s-a retras un pic. Așa. Împinge. Acum, împinge sonda. Nu știu. Sunt într-un cărici, uite, trebuie să merg mai departe aici, uite. Vezi, văzănetul e așa. Ia, nu merge, sunt înduit, ținem teacă. Nu se avansează. Hei, nu știu. Ia, dăm și mine aici. Am forțat nefroscopul puțin. Te vezi, uite cum e. Vezi, uite. Asta e bazenetul, vezi, uite. Vezi unde se vede sonda? E foarte... Așa, da. Sunt în direct?
Da, domnul doctor, vă auziți? Noi vă ascultăm.
Așa, da. Uitați, e un bazenet mai mic. Se vede sonda. E foarte, foarte, foarte mic bazenetul și... Așa. Ia mai dau un pic litoclast, pentru că mă ține foarte tare. Așa. Așa. S-a stricat garnitura. Hai, apăsați. Da, asta este ca să vezi că asta n-avem, am oprit aspirație. Le fragmentez să fie mai ușor de aspirat. Centrarea în bazenet e foarte dificilă. Hai, acum îmi dai să aspir. Poftim? Nu înțeleg. Litoclast. Nu. Chiar că acum noi îl folosim îl folosim pe ureter mai mult decât laserul, că nu lizează. Când avem un calcul ureteral, nu folosim laserul, folosim litoclastul, pentru ce ați întrebat, că nu, să nu lizeze masa mai sus. Ia, dăm și mie tot litoclastul. Sau dai și, gata, dăm o pensă. E foarte greu, uite, mă ține foarte tare, camera e ok, nu?
Da.
Nu înțeleg de ce mă ține foarte, uite, mă ține foarte tare aici. Încerc să îl mobilizez cu pensa, acest cioc. Accesul e mai e greu aici și atunci mobilizez calculul cu pensă să-l aduc în fața mea. Încă un pic. E pe lângă. Uitați, deci încerc, nu pot să deschid mai mult.
Domnul doctor Vasile, ne mutăm puțin la domnul doctor Rașcu.
Hai.
So switching to Dr. Rașcu now.
Okay. Can
Yes,
you hear me?
we can see you, Stefan.
So I was previously telling you that having an operated kidney in an open fashion about 15 years ago in childhood might pose some problems to the orientation. And this is why I did something I don't usually do. This means mapping the pilocalicial system at the end of the surgery after I finished all the stones with contrast enhancement. And that's what I've done in here. So after finishing that, I'm just going to properly mount a magnetic black star stand from Eurotech. This is what I'm going to do now. Okay? Just a second, I've just retracted my sheet a bit, but it went perfectly inside. Now I'm retracting my access sheet, and I'm going to mount the stand onto the guide wire. And of course, using my CR, my fluoroscopy to properly push it inside the renal pelvis. I'm going to be using a 6 French 24 centimeters at length. I usually prefer short and thin stents, generally speaking. I mean, the shorter the loop and the distal portion inside the bladder is, I guess the few the symptoms will be regarding or related to the stent. And in here, the patient isn't very, very tall. The ureter is not that long, so 24 should be the proper size. Ok? Hai să vedem. Așa, mai dăm. Ții tu, te rog, contra de ghid. Pusher. Contra, da? Contra când mă duc aici ca să nu. Hai că ține contra. Okay. Contra, da? Așa, e ok, retragem ușor. Hai. Da, stop. Nu mai dăm rază. Non inferior. duce? Nu, stai un pic, nu mai duce ghidul, că mie că băgăm pe ureter. And of course it wants to go in the inferior callus. Lasă un pic pe mine, ține asta.
Dr. Rashku, we are switching to Dr. Salahedin for just 1 second. Okay. So switching to Dr. Salahedin now?
Da. Deci suntem, dăm sănătrodul. Am eliberat aproximativ bazenetul. Acum este un calice secundar. Dați bazenetul, l-am golit. Asta e sonda ureterală. Nu așa, și dați că bazenetul s-a golit. Aici calicele inferior s-a curățat. Mai fragmente aici, fracții unde s-a produs așa. Și nu vreau să forțez spre calicele superior, că este un unghi foarte, foarte închis, foarte strâns. Și uitați, ne retragem la vedere, nu mai punem son de GG, că nu avem de ce. Așa, stați, urmă. Ia, trebuie să... Întotdeauna când ne retragem la vedere. Deci mai sunt momente când am forțat să avansez, pe lângă teacă, se curăță cu o ușorință, că sunt fragmente. Dar nu mai... Așa, încă o dată, da. Poftim? Da, bine, așa, deci pentru piesa calicială superioară care a rămas, acum o să vă arătăm imediat, dar nu acum. Nu se face acum flexibilă, pentru că am avut și o ușoară sângerare. Da. Nu. Putem să punem în altă zi. Deci, acum ne uităm fluoroscopic. Da, deci ne-a rămas piesa caliciară superioară. O să lăsăm acum sonda ureterală, pentru că în bazenet, cum ați observat, bazenetul e foarte mic și nu se face, nu se stă sonda, bucla superioară a sondei, și luni, iar pacientul rămâne cu sonda ureterală și luni îi trecem cu anestezie locală, o sonda GG, ca să fie pregătită pentru peste o lună de zile pentru o ureteroscopie flexibilă. Vă mulțumim.
Mulțumim, domnul doctor, că pentru această intervenție extrem de reușită, zicem noi. Și o să trecem acum la domnul doctor Rașcu, care cred că este la final și... Switching to Dr. Rașcu now.
Yeah, so just fine-tuning with the stent right now. I've positioned the stent inside the bladder. The loop is smooth. A 24 centimeter stent is too long for this patient, unfortunately. We don't have a shorter one. Pensa. Iau de aici. Ok. E foarte bine. Scoate pensa. Adică bagă pensa pe în canal. Atât. Ok. Scoate de tot. Încet. Mersi, Vali. So I have a nice loop inside the bladder. Still, if I want to put it in the renal pelvis, it will be too long. So I don't think I'm going to try this any longer. I'm just going to leave it like this, maybe. Mai dăm-o pe însă, Mirela. Hai să încercăm să vedem dacă... Da. Deschidă, nu contează că ai prins magnetul. Strânge încet, da, strânge. Ok, hai să mergem cu ea în partea asta, să vedem dacă... N-am, nici pe peretele celălalt n-am. Dai drumul, scoate pensa să văd și eu. Ai dat drumul? Hai, scoate pensa pe canal să văd și eu, așa. Să am imagine. Ok.
So your plan is to leave it like this, no, Dr. Rașcu?
Yeah, most probably. If it stays well like this, why bother? I'm going to take it out anyhow at maximum 10 days. So most probably it will stay like this, okay? Hai mă, dă-mă pens. Ce? Da, voiam să pun uite acolo, în lupul ăla, dar nu pot. Adică nu am lungime. Hai să mai vedem o dată. Ok? Du-te. Da, sigur. Dacă trebuie, punem din nou. Hai. Haide. Nu? Du-te acolo. Strânge. Tare trebuie să strângi pe asta. E foarte rigidă. Ok. Hai să vedem dacă se așează așa. Dau rază. Ține pensa mai scurtă mai lângă mine. Pensa mai scurtă. Pensa mai scurtă. Pensa mai scurtă. Ok. Afară și ghid pe ea. Ok. Gata. Ghid și punem din nou. Nu las nimic așa, e și vesica foarte plină. Nu las nimic așa, o punem din nou. Dau rază. Am mudat ca toți dragi. Da, ușor. Scoatem, ușor, scoate. Da. Scoate. Tot nu se duce acolo. Ia uite ce frumos ăsta în superior. Jos, raza, da. Da. Fix în superior rămâne. Scoate, da? Perfect.
Okay, so you managed to put it in...
You've seen that.
Yeah.
Yeah. I didn't want to leave it still in the inferior calyx. I've placed it in the upper calyx. Maybe less chances of hematuria afterwards. Anyhow, I'm going to take it out fast, maximum 10 days. Fully, not foarte mult.
Thank you.
Okay.
Thank you very much, Dr. Rașcu,
That was it.
for this surgery.
Thank you. Yeah. Mulțumesc, Mirela. Mulțumesc, Georgi. Mulțumesc, Vali. Ce? Ce nu ți-a plăcut? Hai să-ți spun de ce n-a vrut. Rinichiul ăsta pe care tu-l vezi așa în plan, el este basculat așa cu totul. Nimic pe care vezi radiologic în plan nu e real. De-aia nu vrea să se așeze. Adică asta înseamnă operație deschisă și în copilărie. Ce vrei să-i faci? Pielolito la 10 ani de zile. Pielolito la 10 ani. În copilărie făcută. Niciun calice n-avea o intrare normală. Totul așa. Și a făcut un calcul care pleca pe ureter de 1,5, l-am operat acum vreo lună și acum mai avea mișgai berinic. Și am zis că e cazul.
We now live in an era where technology enables us to use minimally invasive surgeries, and retrograde intrarenal surgery had major breakthroughs with the newest developments of flexible ureteroscopy and laser technology. This leaves us to wonder if a surgery that was first used over 50 years ago, with minimal changes regarding its technique, still matters in the modern age. The short answer is yes. Referring to urolithiasis guidelines developed by EAU and AUA, both recommend PCNL as the first-line, gold standard procedure for large, complex, and staghorn calculi. Secondly, we have to think about the stone-free rate. PCNL has the advantage of presenting higher stone-free rates after a single surgery, reducing the economic burden. Thirdly, even though the concept of the PCNL procedure remains the same as it was 50 years ago, improvements in devices used, miniaturization on nephroscopes and sheets, stone fragmentation technologies advancement, improvements in regard to patient positioning, are bringing the PCNL procedure back in highlight with their effect on surgery times, ergonomics, morbidity, and patient safety. PCNL does look great on paper, and it's seductive for beginners to try, but we need to always remember that it comes along with associated risks and complications. I think everyone who performs PCNL knows that it's one of those surgeries in which you hope for the best, but you need to plan for the worst. A standard grading system, modified Clavian classification, provides an objective, stratified grading system for complications and has been adopted in order to compare overall complication rates and the severity of them. The risks of developing clinically significant complications such as bowel injury, sepsis, and death remain low in a study conducted on 698 patients. In regard with the timing of appearance, the complications can be classified as intraoperative, early postoperative, or late postoperative. The intraoperative PCNL complications usually have their origin in one of the three key moments of the intervention: pylocalyceal system puncture, tract dilation, or in the endoscopic maneuvers used for fragmentation and calculi extraction. When it comes to incidence of complications after the PCNL procedure, past publications were indicating a high number, up to 80%. The Scroas Prospective Study evaluated over 5,800 patients and found that 85.5% of the procedures were uneventful, while the most frequent and important complications were significant bleeding, renal pelvis perforation, hydrothorax, the necessity for blood transfusion, and septic complications. Another paper, a review published by Sites, that was also cited in the EAU guidelines, found that in over 12,000 patients, the most frequent complications were fever, the need for transfusion, thoracic complications, organ injury, and urinoma. The relative risk of these complications were approximately similar between the two studies. When it comes to the questions of when, or better said, to whom would these complications appear, a recent paper by Monroy found some risk factors that are more frequently associated with complications after PCNL. These factors may be patient-related, presence of a UTI, the presence of comorbidities, for example, cardiovascular diseases requiring anticoagulation, preoperative hemoglobin levels, anatomical varieties, obesity, horseshoe kidney, present an increased risk for sepsis, bleeding, and a much more difficult access. Stone-related. Larger and harder stones and staghorn calculi increase the risk of bleeding and the operative time. Technique related. Number of tracts, access type used, upper pole access for example, increase the risk of bleeding and organ injury. Experience plays an important role, and during the planning part of the surgery, all patient and stone characteristics must be taken into account, and appropriate technique should be used for best results. Though not by itself a complication, loss of the punction tract might lead to severe consequences resulting themselves in complications, procedure delay, or failure to fragment calculi, the need for additional punctures, longer operative time, increased bleeding risk, either from the lost tract or from the additional punctures, increased radiation exposure. Of course, trying to regain access will lead to longer operative time, will incur a higher risk of organ injury and increased radiation exposure. The best way to prevent the occurrence of tract loss is by taking some precautions. Take your time and position the patient correctly. Throughout the procedure, be careful to always have the sheath and guide wire secured. Be mindful to the movements you make. Ask assistant to hold the sheath in place so it doesn't migrate. Dilate your tract with care so you follow the punction tract you created. In case the tract is lost, there are some ways to recover. Attempt to repass a guide wire if possible. Repuncture on a second punction tract, or, if all fails, postpone surgery and reattempt at a later date. The smaller the channel, the easier it is to be lost. At the University of Hong Kong, 23 cases of nephrostomy channel loss during mini PCNL were identified, resulting in an incidence rate of 2.2%. Methylene blue was immediately injected into the ureteral catheter to facilitate location and retrieval of the channel. Once extravasation of the dye was identified under rigid ureteroscope, a first guide wire was introduced into the channel for maintenance, followed by another guide wire inserted in parallel to facilitate dilatation. The major reasons for PCNL channel loss were mild hydronephrosis and complete obstruction of the target calyx due to renal stones. Bleeding is one of the most feared complications of PCNL. The rates of complications related to bleeding have been estimated between 0 to 20%, with 7% of the patients requiring blood transfusions in a 2025 published review by Monroy et al. Most of the time, bleeding is self-limited and does not require surgical management. An important factor in reducing the risk of significant perioperative bleeding is accurate renal puncture. It has been stated that the safest access from the skin to the renal collecting system is through the long axis of a renal calyceal papilla, a posterior lower calyx, but there is evidence that suggests that non-papillary access is equally safe and efficient as the papillary approach for standard PCNL. The same review also identified the factors that may lead to an increased risk for bleeding: the diameter of the access sheath, the number and size of calculi, and the duration of the intervention. We have to take into account the technological progress from the last years. As we have seen before, many of the complications appeared during puncture and dilation of the tract. By implementing mini-percutaneous nephrolithotomy, MPCNL, which involves creating narrower tracts, less than or equal to 18 French, to allow smaller scopes access to the kidney, parenchymal trauma and bleeding can be reduced, facts sustained by a lower hemoglobin drop in mini PCNL series compared with standard PCNL. Mini PCNL should be considered an effective and reliable alternative to standard PCNL. It achieves a comparable SFR to the latter, but with less blood loss, lower transfusion rate, and shorter hospitalization. We can't control the size and the number of the stones. However, the diameter of the access sheet and the duration of the intervention is a surgeon-related problem. You see here a cast of a kidney with its arterial and venous system. You can easily deduce that a lower diameter of the access sheet means a lower risk of bleeding. A PCNL study that looked on the CROES database has compared the risk of bleeding of different access sheets and found that a 26 French was associated with 3.04 times increased odds of bleeding compared with an 18 French 1, and access sheaths of 30 French were associated with 4.91 times increased odds of bleeding. If excessive bleeding occurs during the intervention, visibility might be severely impaired and the procedure might be impeded. In such case, management of the bleeding includes repositioning of the access sheath, which might help with reestablishing vision to continue the intervention. There are cases, though, when a massive intraoperative bleeding might occur, and repositioning the sheath does not provide better vision. In these cases, the intervention should be stopped and a nephrostomy tube be installed in order to provide tamponade of the bleeding source. Clamping the nephrostomy tube will stop most of the bleeding from venous sources. The K-nephrostomy tamponade catheter has been a valuable and minimally invasive tool for the immediate control of hemorrhage from nephrostomy tracts, intraoperatively as well as postoperatively, thus preventing further blood loss and decreasing the need for more invasive procedures. There are studies to support the use of nephrostomy tube with balloon, Foley's catheter, after PCNL, as this is associated with less pain and comparable hemoglobin drop as compared to nephrostomy tube without balloon. When bleeding presents in the early post-op period, patients' hemoglobin levels should be checked, as most of the time bleeding is self-limited. But if there is a persistence of bleeding and hemoglobin levels drop, more active procedures should be undertaken. Angioembolization, the more modern approach, or nephrectomy if there is either no possibility for angioembolization or if angioembolization fails. Delayed bleeding can occur 3 to 10 days post-op and needs to be identified and treated accordingly. The signs are the appearance of hematuria associated with drop of hemoglobin levels and with the presence of blood clots in urine. Diagnosis needs to be clear, and angio-CT offers the best sensibility and specificity when it comes to identifying AV fistulas or pseudoaneurysms. Management is represented by selective angioembolization or nephrectomy. To summarize, the algorithm for the management of post-PCNL bleeding might look like this. If the bleeding is mild and the patient is stable, we can try conservative treatment, vitals monitoring, HGB evaluation, bed rest, and transfusions if needed. If the bleeding is moderate or severe with important HGB drop, CT angiography should be performed in order to identify fistula, and if vascular injury is confirmed, perform angioembolization. If the patient is hemodynamically unstable, the emergency embolization or emergency nephrectomy should be performed. Renal angiography with selective embolization represents the most adequate treatment for renovascular complications after PCNL, with a success rate of over 80%. A study conducted in our clinic on 2,095 PCNL patients, bleeding requiring angioembolization was present in 22 cases, 1.06% of the patients. Access is provided either through the brachial artery or through the femoral artery. An abdominal aortography is performed, identifying the renal artery, and then, through the renal artery, the branch that is injured is found and hemostatic material, usually a 3 to 5 mm coil made of platinum and shaped like a spring, is inserted as close as possible to the vascular lesion. At the end of the procedure, an angiography is performed in order to confirm that the bleeding stopped. The images are showing a pseudoaneurysm in a patient that presented hematuria 3 days after the surgery. In the left image, you could see the pseudoaneurysm, and in the right picture, you can see the solution, a platinum coil that stopped the bleeding. Injury to adjacent organs are uncommon. Although rare, these complications might have important effects on post-procedural morbidity, so their avoidance is essential. Of course, the best way to avoid these complications is to do careful pre-op planning using CT scans. Colon injury is a rare complication that appears in under 1% of the cases, with an unremarkable difference in incidence between supine and prone PCNL procedures. According to the Clavian classification of surgical complications, colonic injury is regarded as a stage 4A complication. The position of the colon is usually anterior or anterolateral to the lateral renal border, but retrorenal positioning of the colon is found in less than 1% of the general population, more frequently on the left side, and is most likely located near the inferior kidney pole. The risk factors known for colon injury are puncture too far laterally, patients with horseshoe kidney, left side procedure, previous abdominal surgery, decreased retroperitoneal fat tissue, small and mobile kidneys, the presence of a distended colon, and irritable bowel syndrome. In addition, spatial features of the kidney, colon, and percutaneous trajectory channel affect the risk of colonic perforation. Diagnosis is usually made intraoperatively by performing an antegrade nephrogram that shows contrast material outlining the colon, usually pathognomonic for colonic perforation, or using a CT exam. Careful planning using CT images and correct positioning of the patient are key elements in preventing colon injuries during PCNL procedure. The incidence of retrorenal colon during PCNL was assessed in different studies. A parallel line was drawn on CT exam through the posterior edge of each kidney, posterior renal line, at 3 renal levels, upper pole, middle pole, and lower pole. The number of cases with partial colon extension posterior to the posterior renal line was determined. These were further separated to see if any part of the colon extended directly behind the lower pole, middle pole, and upper pole of the kidney. Of the 394 patients included in the present study, 6.9% had retrorenal colon, with 4.6% on the left and 1.0% on the right side. The other 1.3% of the patients had bilateral retrorenal colons. Retrorenal colon is more frequently found on the left side and on the lower pole of the kidney. Therefore, when accessing the lower pole of the kidney, especially on the left side, the risk of colonic injuries should be considered during PCNL. Conservative management is successful in most patients and is based on separation and drainage of the nephrocolic communication. The first step is to withdraw the nephrostomy tube outside the collecting system into the colon as a percutaneous colostomy. Then a JJ stent is inserted for adequate urinary drainage. Initiation of intravenous broad-spectrum antibiotics, bowel rest, and parenteral nutrition are complementary treatments. Under this conservative management, complete healing of the colon may be achieved. The colostomy tube and ureteral stent are removed in a staged manner. A colostogram after 1 week helps in evaluating the integrity of the colon wall. In the absence of extravasation or fistula, the colostomy tube is withdrawn into the retroperitoneal space. If the colostomy output remains low over the following days, the tube can be removed, followed by the ureteral stent a week later if patient recovers. Urgent surgical exploration with colonic resection and/or colostomy is indicated in cases of intraperitoneal perforation, peritonitis, septic shock, or persistent fistula. The necessity of a second operation for the closure of the colostomy causes financial and emotional burden on the patients' relatives, and surgeons. Optimal primary results have been reported for sealing materials used to correct nephrocutaneous and colocutaneous fistula tracts. The sealing material is inserted into the fistula tract via a catheter that is left proximal to the closed fistula tract. Novel treatment concepts for colonic perforation due to PCNL have been suggested, and a successful minimally invasive technique via colonoscopy has been reported. Use of clips delivered through the working channel of the flexible endoscope to seal the entry and exit points of the colonic puncture resulted in no complications and allowed patient recovery. Lesions of the small bowel are extremely rare. Only 12 cases are described in literature. 2 types of lesions are described. Iatrogenic lesions, usually on the right side, caused by over-advancement of the needle during puncture, or spontaneous fistula caused by septic necrosis. When the lesion is identified during the PCNL procedure, we may see contrast extravasation in the small bowel. The presence of amber-colored fluid on the nephrostomy tube, if placed, it is a sign to recognize the complication. If the procedure is done in a tubeless manner, the lesion might not be detected on CT scan. Treatment is complex. If detected during the procedure, stop procedure at once. Conservative treatment can be done if detected early. Placement of nasogastric tube, urinary drainage, parenteral nutrition for 21 days, and total fasting for 21 days. 3 cases are described where this management was successful. Otherwise, surgical treatment with the suture of the defect is necessary. Images on the right, KUB before surgery, fluoroscopy during surgery, post-puncture KUB showing contrast in duodenum. Right picture, Renoduodenal fistula discovered during exploring laparotomy. As shown before, liver injury during PCNL is uncommon, but there are certain risk factors that should appeal for caution. The need for supracostal access, hepatomegaly on pre-op ultrasound or CT scan, and the presence of malrotated or horseshoe kidney. In the images shown on the slide, you can see the nephrostomy tube passing through the liver. The conduit followed in this case that had no hemoperitoneum was conservative treatment with the extraction of the nephrostomy tube 72 hours post-op, in the or with a surgical team on standby. Placement of the nephrostomy tube offers the advantage of compressing the punction tract associated with tamponade of the bleeding vessels. In case of hemoperitoneum, open surgical treatment is needed. We can avoid liver injury with careful CT scan planning and ultrasound-guided puncture when premises for injury are present. In contrast to hepatic injury, where bleeding might not be important if a large blood vessel is not injured, in case of splenic injury, patients will most of the time present with significant hemorrhage, hemodynamic instability, and abdominal pain. Emergency CT scan and splenectomy is the standard and life-saving management procedure. How to avoid it? As with liver injury, planning with pre-op CT and image-guided access reduce the risk for this complication. Lesions involving the thorax are uncommon in PCNL, overall incidence being estimated at 1.5 to 2%. The most common risk factor is represented by an access superior to the 12th rib. In these cases, incidence rises to about 10%, and if access is done superior to the 11th rib, it rises to 25%. Preoperative CT is essential for planning in order to determine the optimal percutaneous access. If supracostal access is used, postoperative chest X-ray is recommended in order to assess for chest complications. Management can be conservative if the patient is asymptomatic, or thoracic drainage and prolonged urinary system drainage are to be chosen in case patient presents signs of instability. Superior calyceal access in PCNL may result in a higher stone clearance rate, a lower rate of subsequent punctures, and a faster operation duration with no increase in postoperative complications or hospital stay for kidney stone patients. Collecting system injuries occur in 8% of the patients. Causes: too far dilation, improper choice of guide wire, overzealous use of nephroscope. Diagnosis is usually intraoperative, extravasation of contrast on fluoroscopy, or direct visualization of paranephric structures of fat. Post-op CT might reveal signs of urine leakage. Minor extravasation, associated with small lesions, usually do not require interruption of procedure, but large lesions / perforation of the renal pelvis with important contrast extravasation will require cessation of the surgery and adequate drainage via double J stent. If incorrectly identified during surgery, urinary extravasation will lead to the formation of urinoma. In case of the development of urinoma, treatment can be either conservative or percutaneous drainage depending on the size. Ultrasound-guided percutaneous nephrolithotomy has been shown in recent studies to have the benefits of being radiation-free, providing a shorter puncture time, requiring fewer attempts of renal puncture in any type of hydronephrosis indicating higher accuracy, and providing a well orientation towards the adjacent organs, making their injury less liable, while keeping the same stone-free rate as fluoroscopic puncture. The development of artificial intelligence enabled the creation of automated renal access robots. Using X-ray obtained during surgery, these systems determine the safest and most accurate path for gaining access. The ANT-X, automatic needle targeting using X-ray robot, which is currently evaluated in global multi-center studies, shows great promise. In a randomized, single-blind clinical trial published in AUA's Journal of Urology, which evaluated 71 patients with PCNL who had access created either by ANT-X system or by US guidance, the ANT-X system showed more accurate access compared to US. Access was achieved needing less punctures, 1.82 versus 2.51, and a shorted puncture time, 5.5 minutes versus 8 minutes, showing promise in reducing perioperative complications linked to renal access. Infection is the most common complication that occurs after PCNL. Although uncommon, it is important to remember that sepsis has been reported as the most frequent cause of death in patients who had PCNL. A systematic review involving nearly 12,000 patients reported complications associated with PCNL, with fever occurring in 10.8% and sepsis in 0.5% of cases. Antibiotic treatment in patients with positive urine culture should be started 7 days prior to surgery. This prolonged antibiotic treatment will significantly reduce the incidence of sepsis compared to a single dose of preoperative antibiotic. It is important to note that even in cases where urine culture was sterile, there is always a bacterial charge in the stone, which will be released upon fragmentation. Up to 43% of patients with negative urine cultures had positive renal pelvis cultures, these patients presenting a high risk for developing sepsis. High levels of intrarenal pressure may be reached intraoperatively, irrespectively of the technique, when inflow and outflow are not balanced, and may cause pyelovenous backflow, as well as rupture of the collecting system, leading to postoperative infectious complications. IRPs lower than 30 cm H2O should be maintained during endourological procedures to avoid complications. Duration of increased intrarenal pressures, the amount of perfusion pressure, obstruction, and irrigation fluid volume are independent predictors of complication development. Bacteremia is a result of an infected urine, fragmentation of infected stones, and pyelovenous backflow. Risk factors for septic complications after PCNL include positive urine culture, infected calculi, stone size, multiple puncture tracts, prolonged operation time, diabetes, patients groups with unique anatomical characteristics, horseshoe kidney, spinal cord injury. Management of sepsis should start with early recognition of sign and symptoms, blood cultures collection, correction of hydroelectrolytic imbalances, immediate IV antibiotic treatment, and in case of hypotension, vasopressor therapy should be initiated. Imaging investigations should be done in order to rule out obstruction in case of tubeless PCNL or obstruction of JJ stent in cases where nephroscopy tube is not used. Some preventive measures for PCNL complications. Patients should be prepared with antibiotic therapy before surgery according to their urine culture. Prolonged therapy is preferred for patients with positive cultures. Imaging should be done before surgery. CT scan is preferred in order to plan correctly the access site. Predictive tools such as Guy's stone score and/or the stone nephrolithometry can be used to determine the complexity of the surgery, and it might offer information about the stone-free status after surgery. Another safety measure is, of course, to avoid creating multiple unnecessary tracks, so choose the appropriate access site. As a mean for reducing pressure and backflow, new technological advances were developed integrating suction into lithotripters, combining ultrasonic or ballistic energy and active aspiration into a single lithotripsy probe. Devices like Shock Pulse and Trilogy offer very efficient stone fragmentation and fast removal of stone fragments, becoming increasingly used for large kidney stones. Another option are represented by the active aspiration nephroscopy sheaths available in both reusable and disposable forms, exclusively for mini PCNL. Studies show that using these active aspiration devices reduces IRP and operative time, and so they are also effective in reducing the risk of sepsis, is improving stone clearance, enhance vision, and improve lithotripsy efficiency, which make it a very attractive evolution for PCNL in any stone volume. We can connect a mini nephroscope to a pressure suction in order to reduce intrapelvic pressure. A study published since 2016 showed that the infection rate was only 6.4% among 683 urolithiasis patients with UTI in Group A, similar with those patients without UTI who were treated by this modified mini PCNL in Group B, 4.9%, but significantly lower than those patients with UTI who were treated by the traditional MPCNL without pressure suction in Group C, 28.4%. Pressure in the calyces may depend on the irrigation fluid and the space between the nephroscope and the calyces. Using a small nephroscope, the space between the nephroscope and calyx neck was larger than when the traditional nephroscope was used. This may be a useful method to reduce the intracalyceal pressure, Even more important is the fact that the mini nephroscope combined with pressure suction can be used at any time to aspirate pus and thus reduce pressure on the calyces. A newer technology development that might help in reducing post-PCNL complications is using the aspiration-assisted access sheaths. The need for such device appeared when mini-perc PCNL started to become more used. Reduced diameter nephroscopes created the premises for increased intrarenal pressures, which was previously shown that is associated with infectious complications. So the active aspiration has the role to reduce intrarenal pressures, reducing the risk of pyelovenous backflow. In a review by Nazardo et al., was shown that comparing standard mini-perc to active aspiration mini-perc, a lower risk for postoperative fever was shown in the aspiration sheath mini-perc group. Other important metrics as bleeding risk and stone-free rate were similar between patients with standard mini-perc versus active aspiration mini-perc. Another advantage of the active aspiration sheath was in reducing operative time, on average with about 20 minutes, which by itself is important in reducing the rate of complication. A suctioning lithotripsy sheath may reduce operating time, the amount of bleeding, the incidence of complication, and can improve the stone-free rate even in patients with pyonephrosis. I wish for your patients to be considered a part of a kidney stone survivals club and not to rely on the fact that they have a kidney to spare. As with any surgical intervention, the first question we must address is why and when a percutaneous approach should be employed. Traditionally, the main indications have centered on stone disease, decompression of the upper urinary tract in cases of obstructive pyelonephritis or acute renal failure caused by migrated calculi, and stone removal via percutaneous nephrolithotomy. However, its applications extend beyond kidney stone disease. In uro-oncology, percutaneous access may be indicated for drainage in septic patients with malignant obstruction as a route for endourological interventions such as tumor fulguration, laser ablation, or resection, for the local installation of medications or chemotherapeutic agents directly into the pylocolocele system, or for biopsy of a suspected urothelial lesion. Additionally, the percutaneous approach provides valuable diagnostic opportunities, including antegrade pyelography, particularly in the evaluation of a urographically silent kidney, and functional testing such as the Whittaker test, which helps to distinguish between obstructive and non-obstructive causes of hydronephrosis. The next question we must address is, how should a renal puncture be performed? The first percutaneous renal access was achieved by Willard Goodwin in 1955, using the prone position. For more than 3 decades, this remained the standard approach, laying the foundation for modern techniques of renal access, stone management, and even upper urinary tract tumor treatment. In 1987, Valdivia introduced the supine approach, which gradually gained some adoption, particularly in Europe. However, it never achieved universal acceptance. A likely reason is the natural reluctance of surgeons to abandon a technique that already demonstrated high efficacy and low morbidity, such as the conventional prone access. Since then, the debate over prone versus supine positioning has remained ongoing. Yet, despite the advantages of the supine approach, approximately 80% of urologists worldwide continue to perform percutaneous renal surgery in the prone position. Obtaining a safe and precise percutaneous renal access is the hallmark of a good percutaneous surgery. The prone position provides posterior access to the collecting system that theoretically enables the surgeon to puncture a posterior calyx through Broddel's avascular renal plane without causing significant parenchymal bleeding. Ease of percutaneous access to the kidney between prone and supine position is the matter of an ongoing debate. A comparative analysis of CT urograms found shorter tract length and increased potential access sites in favor of prone position. Consider this analogy. If you were to land an airplane, would you prefer a narrow, unstable runway or a broad and stable one? The prone position offers several clear advantages. It provides a larger surface area for puncture, greater working space for instrument manipulation, unrestricted instrument excursions, and facilitates multiple access tracks when necessary. By contrast, the supine approach presents certain limitations. The flank is only partially exposed, making the initial puncture more challenging. Access to posterior calyces may be restricted, and puncture of the upper calyx is technically difficult. In addition, the longer skin-to-calyx distance in supine cases often requires longer sheaths and dilators, while nephroscope maneuverability is reduced. In addition to facilitating access to the renal pelvis and other calyces with fewer punctures and fewer complications, access through the superior calyx also enables the nephroscope to be aligned with the long axis of the kidney in comparison to other access points. This enables the surgeon to achieve access in the wherever place the tumor develops. Prone position offers the option for a superior calyx access. Torque applied to a rigid nephroscope in the attempt to reach a different calyx is the single most important cause of bleeding during percutaneous renal surgery and is largely responsible for increasing transfusion rates and urine extravasation. The supine approach to percutaneous renal surgery provides a series of distinct advantages that make it an increasingly valuable alternative to the traditional prone position. From the anesthesiologist's perspective, ventilation is significantly improved, which is particularly beneficial in obese patients and those with cardiorespiratory compromise. From the surgical standpoint, supine positioning uniquely enables ECIRS, the combined retrograde and percutaneous approach, offering the possibility of achieving complete access to the whole paleocalicial system. Access to the superior calyx is also facilitated as the trajectory of the puncture is more direct, reducing torque on the parenchyma and improving safety. Finally, when access is obtained through the posterior axillary line, the working sheath lies in a nearly horizontal orientation, optimizing ergonomics, enhancing precision of movement, and reducing surgeon fatigue during lengthy procedures. These elements together underscore the practical and clinical value of the supine position. The cornerstone of any percutaneous renal procedure is secure and accurate access to the collecting system. In this case, puncture is performed with the patient in the prone position. Guidance is achieved by combining fluoroscopy, which provides the general direction of the needle, and ultrasound, which allows continuous, real-time visualization of its advancement. This dual modality approach maximizes precision while reducing the risk of complications. Once the optimal trajectory has been defined, puncture is carried out under ultrasound guidance, targeting the desired calyx, and in this example, a lower posterior calyx. Careful attention must be paid to maintaining the correct needle orientation on ultrasound throughout the puncture. As the needle traverses the fascial planes, even minor deviations in its course may result in difficulties during subsequent steps, particularly kinking of guide wire after the needle is extracted. On the fluoroscopic image to the right, a right-sided double J stent is visible, showing significant calcification of the distal loop. Such findings are not uncommon in patients with indwelling stents that have remained in place for an extended period. However, the presence of incrustations increases procedural complexity. After advancing the needle into the targeted calyx, successful entry is usually confirmed by the spontaneous outflow of urine through the needle. However, if no efflux is observed, gentle aspiration with the syringe should be performed to verify intrarenal placement. Another reliable method of ensuring that the puncture needle is correctly placed within the paleocalicial system is to inject a small amount of contrast under fluoroscopic guidance. This should always be done gently and in a controlled manner. If the needle is properly positioned, the collecting system will opacify promptly and uniformly, outlining the calyces and the renal pelvis. Once access to the desired calyx is confirmed, a guide wire must be advanced through the puncture needle. This step is essential for maintaining the tract, as it effectively seals the access pathway. By securing the guide wire in place, the risk of losing the puncture tract, a serious and feared complication, is virtually eliminated. Teaching Pearl. Always confirm free guide wire mobility within the collecting system under fluoroscopic or ultrasound guidance. Resistance or restricted movement may indicate malposition and should prompt immediate correction before proceeding. Tract dilation is performed progressively using either sequential polymer dilators or single-step metallic dilators. In this case, polymer dilators were selected as they provide a more controlled and less traumatic dilation compared to the more aggressive metallic counterparts. Teaching Pearl. Whenever possible, match the dilation method to the clinical context. Polymer dilators are preferred in standard cases for their gentler tissue handling, while metallic dilators may be reserved for situations requiring rapid or forceful access. Once tract dilation is complete, the nephroscope sheath can be safely introduced. In this case, an active aspiration sheath is employed to minimize intrarenal pressure and reduce the risk of infectious or hemorrhagic complications. Through this sheath, the nephroscope, or alternatively a resectoscope, can then be advanced to perform the planned procedure. Teaching Pearl. Active aspiration sheaths not only control intrarenal pressure, but also improve visibility by continuously clearing debris and irrigation fluid. In this second video, the kidney is approached in the supine position, a technique that presents distinct challenges compared to the prone approach. Careful attention should be given both to patient positioning and to the puncture trajectory, as the skin to calyx distance is typically longer and access is technically more demanding. Percutaneous entry is performed under combined fluoroscopic and ultrasonographic guidance, allowing clear visualization of the needle's orientation on fluoroscopy and its progressive advancement on ultrasound. A valuable technical pearl in the supine setting is the use of a diamond-tip puncture needle. Its superior penetrating capacity enhances precision, reduces the risk of deviation when traversing fibrous fascia, and ultimately facilitates a safer, more controlled access to the collecting system. Did you catch that? This demonstration also includes another tip for the instances when you have a difficult access: the double guide wire technique. Inserting 2 guide wires during access and dilation will allow you to insert the Amplatz sheath or aspiration sheath in a safer manner. 1 guide wire will stay anchored, and it will be kept for safety in case the tract is lost during surgery. Now the procedure continues as in prone position. The sheath, in this case also an active aspiration sheath to keep low intrarenal pressures, is inserted. Note the constant visualization under fluoroscopy until the sheath reaches the pielocalicial system. In situations where ultrasound-guided puncture proves difficult or even impossible, such as in the absence of upper urinary tract dilatation, a freehand fluoroscopic puncture may be performed. However, this technique requires a high level of experience and refined tactile feedback. In the case presented, the patient exhibited a complete pielo-ureteral duplicity with total obstruction of the upper renal unit. The initial puncture, performed under ultrasound guidance, was not fully successful. Although the needle entered the pielocalicial system, it did not do so in a transpapillary fashion. Nonetheless, this attempt allowed the introduction of contrast, enabling better visualization. As shown in the photo, our colleague demonstrates the correct trajectory. Let's call it the genesis of kidney puncture. It is important to observe how the kidney shifts when pushed by the advancing needle. This highlights the essential skill required: the operator must be able to feel the needle as it traverses the renal parenchyma and then enters the calyx. Once appropriate access is achieved, placement of a guide wire ensures the tract is maintained and secure for subsequent steps of the procedure. Of course, these kind of cases would be impossible to resolve without a dedicated team. Yes, this is a shout out to my colleagues and to the whole endourology team. Now, some take-home messages from this presentation. Percutaneous access can serve both diagnostic purposes, such as direct visualization and biopsy, and therapeutic ones, including laser ablation, fulguration, or resection. In terms of positioning, the prone approach is most frequently used, as it provides reliable access with low complication rates. The supine position, while more technically demanding, is particularly valuable for ECIRS, offers better ventilation, and allows more favorable access to the superior calyx. Imaging guidance is ideally achieved through a combination of ultrasound and fluoroscopy, ensuring both accuracy and safety, although in selected cases an experienced operator may perform a freehand fluoroscopic puncture. Finally, technical refinements, such as diamond tip puncture needles to improve penetration and reduce deviation, and the double guide wire technique to enhance control in difficult situations, can greatly improve outcomes. The first PCNL was performed back in 1976 in prone position. In 87, Valdivia came with a new approach, PCNL performed in supine position, which was slowly adopted by urologists during the next decades, particularly in Europe. Supine PCNL has not gained wide acceptance in the urologic community. A plausible reason for that is the surgeon's reluctance to utilize new techniques once high efficacy and acceptably low morbidity are achieved with conventional prone PCNL. Since then, there is an eternal debate about which position to choose, but still 80% of urologists are performing the PCNL in prone. According with the European Association of Urology, the PCNL performed in prone is equally safe as the procedure performed in supine position. As you can see from the previous slide, the EAU is citing this review and meta-analysis of current literature. Apart from a decreased operating time, since we don't have to reposition the patients after ureteral catheter insertion, there was no evidence for a significant difference between prone and supine positions for hospital stay, non-lower calyx puncture rate, number of puncture attempts, and tubeless intervention rates. Data on overall complications rates, mean post-operative blood loss, and transfusion rates show no evidence for a significant difference between the two procedures. Overall, SFR in both prone and supine position was relatively high, 82% and 80% respectively. A particularly high SFR with superiority in favor of prone position was found 14 days after surgery, 92% versus 84% respectively. This finding might be attributable to factors like multiple tracks in prone compared to supine PCNL. Nevertheless, this observation questions whether limiting factors of supine position, such as collapse of the pylocalyceal cavities, may overweight the comparatively favorable gravitational fragment evacuation during supine PNL to achieve a stone-free status. Another study used Endourological Society, CROES, PCNL Global Study Database, including 5,803 consecutive patients who were treated over a one-year period at each of 96 participating global centers. In contrast to supine position patients, prone position patients were more likely to receive a puncture at upper pole of the kidney, 11.4% versus 4.0%, as well as punctures at multiple sites. The stone-free rate at 30 days post-PCNL was significantly higher among prone position patients, 77.0% versus 70.2%, p less than 0.0001. The rate of failed procedures, in which access to the kidney was not accomplished, was slightly higher among supine position patients. Mean operative times was actually 7.4 minutes longer during supine than prone PCNL, a finding that remained true regardless of the method of tract dilation, balloon or telescopic. It was also valid for the sub-analysis of centers performing only supine or only prone-positioned PCNL. Obtaining a safe and precise percutaneous renal access is the hallmark of a good percutaneous surgery. The prone position provides posterior access to the collecting system that theoretically enables the surgeon to puncture a posterior calyx through Brodell's avascular renal plane without causing significant parenchymal bleeding. Ease of percutaneous access to the kidney between prone and supine position is the matter of an ongoing debate. A comparative analysis of CT urograms found shorter tract length and increased potential access sites in favor of prone position. It allows for a broader surface area for percutaneous access with more medial access. If you were to land a plane, would you rather choose a narrow and mobile runaway or a wide and stable one? The prone position provides several advantages, including a larger surface area for the puncture site, a wider space for instrument manipulation, unlimited instrument excursions, and feasible multiple accesses. The main limitations of supine PCNL is that the flank is not fully exposed, making initial puncture challenging. Access to posterior calyx is not always possible. Upper calyx puncture is difficult. If supine position is adopted, longer access sheaths and dilators are used to overcome the longer tract faced in this position, and the mobility of the nephroscope is reduced. Not only that the puncture area is narrow, but also another important drawback of supine position is the mobility of the kidney during percutaneous puncture and subsequent dilation, especially in patients with BMI less than 25. A recent study found that kidney displacement can occur in up to 1/3 of supine PCNL cases. Although it does not alter the success and complication rates, it is associated with longer fluoroscopy times and, therefore, more difficult access. Puncture through a lower calyx, longer renal artery, and lesser perirenal fat measurement were identified as factors associated with significant displacement. In the supine position, percutaneous puncture comes from a more lateral position on the patient's flank than in prone, increasing the patient's tract length. The point at which the renal access sheath enters the kidney acts as a fulcrum. The farther this fulcrum is from the skin, for example, longer access tract, the less maneuverable the distal end of the sheath will be within the collecting system. As a consequence, the surgeon may need to adjust the technique to accommodate limitations in rigid nephroscopy or excessive torquing in the supine position. These limitations may be overcome by routine use of a flexible nephroscope during supine PCNL. When planning to perform supine PCNL, it may be useful to have longer-length rigid nephroscopes and Amplatz sheaths. The Amplatz sheath can migrate beneath the surface of the skin when performing supine PCNL in obese patients. PCNL in supine position is increasing upper calyx endoscopic approachability through the lower calyx tract compared with prone PCNL. Sofer et al. Demonstrated that it is possible to reach the upper calyx from the lower calyx puncture in 80% of cases for supine PCNL, compared with only 20% of cases of prone PCNL. We can overcome this advantage of supine puncture since, in prone position, the upper calyx puncture is easier to perform and in a more medial position on the patient's flank, that is, closer to the spine, than the supine position. For a small subset of patients, those with retrorenal liver, spleen, or colon, the safest window for puncture is via the upper pole and close to the spinal column. A review on 16 studies with 8,541 individuals evaluated the superior calyceal access's performance and safety in relation to other calyceal access during percutaneous nephrolithotomy. The results of the study presented showed that superior calyceal access in PCNL may result in improved stone clearance rate, lower additional puncture rate, faster operation time, and no increase in postoperative complications or hospital stay for kidney stone patients. In addition to facilitating access to the renal pelvis and other calyces, access through the superior calyx also enables the device to be aligned with the long axis of the kidney in comparison to other access points. Torquing a rigid nephroscope in the attempt to reach a different calyx is the single most important cause of bleeding during PCNL, and is largely responsible for increasing transfusion rates and urine extravasation. In addition to facilitating access to the renal pelvis and other calyces and achieving a satisfactory stone-free rate with fewer punctures and fewer complications, access through the superior calyx also enables the nephroscope to be aligned with the long axis of the kidney in comparison to other access points. Prone position is easier for the surgeon to make a superior access. Torquing a rigid nephroscope in the attempt to reach a different calyx is the single most important cause of bleeding during PCNL, and is largely responsible for increasing transfusion rates and urine extravasation. PNL with a single-channel approach, associated with repeated attempts by the nephroscope to reach each calyx, could damage the calyx neck, causing multiple complications such as bleeding, blood transfusion, and urinary extravasation. ECIRS, endoscopic combined intrarenal surgery, combines PNL with RIRS in a minimally invasive method for treating complex upper urinary tract calculi. This combination can decrease the number of puncture channels used to treat complex upper urinary tract stones and has the ability to improve the stone clearance rate in a single operation. The patient position is the cornerstone to do a perfect combination of PNL and RIRS. The most popular position is the Galdical modified supine Valdivia position. Conversely, it has some disadvantages, including the limitation of the puncture site, especially for an upper calyceal puncture with a risk of visceral injury, decreased perfusion pressure due to the influence of gravity during PCNL, because the direction of the tract is slightly inclined downward, the renal collecting system being inadequately filled. The aggregation of bubbles will affect the clarity of vision. The prone split leg position may be used for ECIRS, allowing smooth insertion of the ureteral access sheath, efficient retrograde intrarenal surgery, and ample puncture space. Posterior calyceal and proximal ureteral calculi will be collected in the renal pelvis under the effect of gravity. The depth of the puncture tract is shorter and can be repeated with more than one access in the prone position, which improves the safety of PCNL. Both studies revealed no statistically significant differences between both groups regarding stone-free rate, operative time, number of punctures, percutaneous access time, fluoroscopic time, blood loss, complication rate, and hospitalization time. The ECIRS technique has become widely accepted in clinical practice and is often discussed in clinical research for the staghorn calculi management. However, there are still some concerns that prevent ECIRS from gaining more widespread adoption because this procedure requires two sets of surgical equipment, namely lithotripsy and endoscopic equipment, two sets of imaging displays, and two experienced surgeons. With less equipment and surgeons, the PCNL combined with anterograde flexible endoscopy technique can also manage staghorn calculi like ECIRS. Compared with flexible cystoscope, flexible ureteroscope has a larger bending angle at the front end and a wider observation range. The results showed that PCNL assisted by an antegrade flexible ureteroscopy had a higher stone-free rate, SFR, and required fewer percutaneous tracts with a shorter operation time compared to standard PCNL, P less than 0.05. Performing anterograde flexible ureteroscopy can maintain low-pressure perfusion of the kidney, which helps to decrease the risk of post-operative infection. Flexible ureteroscope was superior to flexible cystoscope in the observation of various renal calyces, especially the parallel calyces. That is because flexible ureteroscope has larger degree of distal deflection, but a smaller distal outer diameter compared to flexible cystoscope. PCNL performed with flexible nephroscopes has also been reported to significantly improve the SFR for staghorn stones and makes the procedure safer, more efficient, reduces the risks of bleeding and related complications. The successful development of the novel percutaneous digital flexible nephroscope allows it to be used either independently or as an adjunct in complex stone cases, providing more effective and safer surgical equipment for percutaneous nephrolithotomy. It was stated that the prone position is associated with a higher risk of urinary tract infections, including sepsis, because of the high pressure in the pelvis. In supine position, the angle of the renal sheath typically is parallel to the floor or angled downward facing the floor. This is the opposite of the orientation of the renal sheath during prone PCNL, where the sheath is angled upwards towards the ceiling. Angulation of the renal sheath during supine PCNL therefore results in increased drainage of fluids and stone fragments from the kidney. This continued spontaneous evacuation of fluid from the renal pelvis in the supine position could potentially lead to decreased renal pelvis pressures and theoretically lower infectious risk after PCNL. High levels of IPP may be reached intraoperatively, irrespectively of the technique, when inflow and outflow are not balanced, and may cause pilovenous backflow as well as rupture of the collecting system, leading to post-operative infectious complications. IRPs lower than 30 cm H2O should be maintained during endourological procedures to avoid complications. Duration of increased IRPs, the amount of perfusion pressure, obstruction, and irrigation fluid volume